Good morning to everybody. Uh, so, as you have all seen in the webinar communication, this is about COVID care centers in apartments, the what, the why, and the how. Now, before I begin the introduction, let me be very clear about one point. According to government guidelines and the legal rules that are applicable in this pandemic scenario, if your symptoms warrant hospitalization, then you must be hospitalized. The COVID care center is not an alternative to an hospitalization. It is only a support system given to hospitals. We are all well aware that this pandemic crisis has put our medical staff and the medical infrastructure in a soup. So hospitals are understaffed and sometimes they're running short of beds. The average waiting time for an ambulance for critical patients is anywhere between 3 to 4 hours, and sometimes even more than that. Now, the COVID care center in apartment communities is supposed to give a support to these people who are waiting for hospital beds or they're waiting for an ambulance. At the same time, there are also patients these days who are either asymptomatic or they show very mild symptoms and are advised to go in for home care. Now, sometimes the family may not be equipped to take care of such a patient. In such cases, the community can come together and these COVID care centers can help them out. So, in this webinar, we have two expert speakers, that is Dr. Ferzaan, engineer from Nightingales Home Healthcare Services. Dr. Ferzaan, if you could just say a hi to everybody. Dr. Ferzaan, you're on mute. Then we have Dr. Dhruv Joshi. Dr. Dhruv Joshi is the co-founder of Cloudphysician and he's an expert at intensive care unit. And we have Mr. Manish Bansal. He is part of the COVID-19 ER team at Rohan Vasanta, and Rohan Vasanta is one of the first apartment communities who have already set up a 6-bed facility COVID care center within their apartment community. The panel will be chaired by Meera. She's the co-founder of Citizen Matters, and they have been doing a lot of stories surrounding COVID care centers. So now I'll pass on the mic to Meera, and she will be chairing the panel for today. Thank you.
Thank you.
Thank you, Karnika. Good morning, everybody. Welcome to the panelist. Today, the format is going to be very simple. The format is going to be very simple. So I'll do a brief context setting, and then I will invite the three panelists to give a brief introduction about their work, about their experiences. And I have a few questions for them, and then we open it up to the audience. And I'm sure a lot of you have a lot of questions. When you are asking questions, please put it on chat first. And then, because I don't know how many questions we'll have, we also have a lot of people who had reached out to us earlier during the registration format time to ask specific questions. So we will be taking some of those also. And so today, if you have any additional questions, just put it on chat, and then we can pick some of them and actually, perhaps invite you to, explain that, or just pick it up off the chat too. Depending on the time, we can figure that out. So let me just give a brief context setting here and why we are here. So we know the current situation here. We have around 20,000 odd people at the current time who are positive in the city, mostly asymptomatic or mild, but there are obviously a few serious cases as well. Given the situation, we know our health infrastructure is very, it's overburdened, and the primary role in this situation is whenever any resident becomes positive, the primary task is with the local government, which is the BBMP. So BBMP is supposed to come, sanitize the place. They have to mark the containment zones. They have to do contact tracing. So they have a lot of responsibility there. However, given the current situation, they are also extremely burdened. They don't have the time. Sometimes it takes a few days for them to come because once the fever clinic, the patient goes to the fever clinic, and then the test labs will inform BBMP as well. So mostly they will be clued in, but they don't have the bandwidth to immediately come and attend to individual cases at this point. Therefore, it is, it makes sense for any resident associations, especially apartment associations are very strong. And it makes sense for us all to jump in and actually help BBMP before they come and while they're there to, make that job easier. We also need to support residents and handle the waste management and all the other responsibilities that we have to ensure that the patient is kept comfortable as well as other residents are kept safe. Now, given that, so in the last few weeks, this concept of, home care is becoming more popular because BBMP also said that especially asymptomatic and mild patients, people with mild symptoms can be quarantined at home, isolated at home, but in some situations that may not be possible. So then the RWS came into the picture saying, we do have common facilities. Can we create these centers with specific infrastructures to kind of provide this interim support so that the patient is helped, situation doesn't get too bad before they can move to the hospital. So that was the starting point of this conversation. Earlier this month on July 1st, the government passed the orders. They allowed home isolation, and by 10th they had decided to allow RWS to create their in-house COVID care centers. So which means that if a patient with very mild or no symptom, they have three options. One, home isolation. They can isolate at the community center or in a government facility. So we're talking about the first two situations today. What is it that people can do if they're tested positive? What they need to do at home, as well as what an RWA needs to do in the common facility. So I now request the panelists to kind of give a brief introduction, starting with Dr. Ferzaan. He will be talking about the importance of supporting local communities and the patients. So what is this ecosystem? How does testing happen? How does remote monitoring of the patient and the clinical parameters can happen? What sort of counseling and nutrition needs have to be kept in mind, and so on. So over to Dr. Ferzaan.
Thanks, Arati. I do two things. I run a home care company called Nightingales, and we're in 4 cities with about 800 people working with us. And I also run a cancer hospital called Site Care, which is in Bengaluru. So COVID has touched us on both fronts. And this is true also of my co-panelist. We have seen COVID in a hospital setting as well as in a community setting. So very happy to be having this conversation. If you look at the COVID problem in India, it has two aspects. One is a very comforting one, and the other is a very alarming one. So if you look at population adjusted cases, India is among the lowest in the world. We are about 670 per million versus about, I think it's about 10,000 for the US and Brazil, 10,000 cases per million, and about 4,000 for the UK. So we are way down. It is also true for number of deaths per million, where we are reporting 20 deaths per million versus on an average in the Western world, about 500 deaths per million. The alarming thing, however, is this could just be the tip of the iceberg, so to speak. So if you look at just 2 months back, we had 1 lakh cases, we had 100,000 cases. Right now, we have 1 million cases. So we have grown 2 orders of magnitude in 60 days. If you extrapolate this trend, in 4 months, you could reach 100 million. I'm not suggesting we will, but it is an extremely alarming trend. And hence, the lockdown, in my opinion, was inevitable. Our hospitals have been hit by a tsunami, literally. We don't have, in the order that is required, the equipment. I'm realizing very recently in our hospital that oxygen is a problem. You need massive amounts of oxygen. For one, not for the hospital, but for one patient, you need massive amounts of oxygen. And the biggest problem, which is why it's hard to get a bed properly, is not so much the equipment, but the people. Where are the doctors? Where are the nurses? You need ICU trained nurses, which even in normal circumstances are hard to recruit. And now they last only for a few hours in the protective gear. So you need, Dr. Dhruv will know the numbers better, but you need dozens of nurses just to manage a mid-sized ICU. Uh, uh, there are very few highly qualified intensivists and pulmonologists in our country. So given all this, we said, how do we solution for this as a home healthcare company? So we researched it. We also did a deep dive into testing. I think I would urge everyone on this call to really read up on testing. What does a COVID panel mean? What does each test actually tell you, and what does it not tell you? There are a lot of ads about various people doing various tests, but I think one has to analyze each test and figure out that at this point in time for us or for our community or for a patient, which is the right test to do and what information is it giving us. I think now the ICMR has released fairly clear guidance, which I'm sure one can look up. But there isn't anything like a COVID test. There are a whole bunch of tests, and they need to be thought through. You have to think about how sensitive it is, how specific it is, how accessible, how much time does it take, how affordable it is, how scalable it is. It's a subject in itself. So just to summarize, we can now go, we created an ecosystem and basically said out what we can realistically do and also equally figure out what we realistically can't do. So I was very happy to hear in the beginning the comment that, I mean, it's not like you set up something in a clubhouse and you can just treat every single person there. One has to figure out what is scientifically valid, what's legally valid, what's clinically prudent. So what we do today is we will sign up a community. We will create access to a large panel of doctors who are interviewed and certified by us. We've worked with a big IT company called Tech Mahindra to create a teleconsultation platform. We've done thousands of teleconsultations. So people can access us, talk to our doctors, and if there is a need, we will recommend a COVID test, and someone from our ecosystem, or for that matter, anywhere else, a test can be done. And if positive, the person can be monitored at home. The doctor calls, nurses call to take symptoms. Possibility to also bring in nutritionists, physiotherapists, other type of more holistic care. And then if we can't manage like this, you can't take chances because people turn very quickly from asymptomatic and mild to more than mild, which is moderate or severe. And that's where we reached out to Dr. Dhruv and Cloudphysician. I'm not aware of any other agency which has this level of expertise. They're super specialists. And we basically said, they also help us in our hospital, so we have a long-standing friendship. And we said, if a regular doctor can't manage this because it's too complex, then Cloudphysician comes in and provides super specialist attention to that patient. All this is happening largely in the digital world. And after that, one has to work out protocols to find a hospital bed and move the person in the unlikely event that is required. I don't think we should be alarmed because not many end up in a hospital, but we have to be very focused about those who do need to get to a hospital. So I would say the vast majority of us, 95% plus or whatever, don't need to be alarmed at all. We are not going to end up in a hospital. But at the same time, we have to be exquisitely prepared for the small numbers that have to go into a hospital. And I guess that's where my expertise ends. So I'll hand over to Dr. Dhruv. Thank you.
Thank you, Dr. Ferzaan. Dr. Dhruv, if you could just quickly summarize the whole concept of remote monitoring and remote ICU and how that works in this current context, that'd be great.
So I'll start with thank you, Dr. Ferzaan. Thank you, Meera. I'll just start with a little bit of background about who I am and what we do. I am a pulmonologist and an ICU specialist doctor. I super specialized in pulmonary medicine and in intensive care medicine. I did my initial training here in India, following which I moved to the United States and I worked and trained there for several years before moving back to India to start a company called Cloudphysician, which I run along with my colleague, Dr. Dilip Raman. Now, the reason that we came back to start Cloudphysician was because we realized that India had a huge shortage of ICU specialist doctors. 9 out of 10 patients in an ICU in India, even prior to the onset of COVID, did not have access to ICU specialist doctors. And this was an alarming number, but and one that many people don't know about, but this happened to be the reality. And that is what motivated us to move back to India and start Cloudphysician, with the goal of getting ICU expertise to hospitals that do not have access to ICU specialist doctors. Now, unfortunately, it is not possible to train and deploy these people in all the locations that they need to be, because it takes over a decade to train an ICU specialist doctor. And so we're never going to be able to fill that gap anytime soon in any way other than using technology in the best way possible. Now, technology obviously does not replace uh, having an ICU specialist doctor at your bedside, but it's probably the next best thing if you can't have one. And it is with that goal that we started Cloudphysician. And over the last 3 years that we have been in operation, we are working with several hospitals to provide this ICU expertise remotely using technology. One of the hospitals that we work very closely with is the hospital that Dr. Ferzaan runs, SiteCare, a really good partner hospital of ours located here in North Bangalore. Now, with COVID upon us, clearly an already underlying problem, an already existing fault line in our healthcare delivery system has been exacerbated several fold. So we already had a shortage of ICU specialist doctors, and now that shortage has just been blown open way more. And in this setting, what we are finding now, coming to the current scenario that we are seeing in our city, including Bangalore, is the fact that not only are we short of ICU specialist doctors, but we're also short of ICU beds, and we're short of nurses. And across the board, the healthcare delivery system, while already strained even prior to COVID being upon us, is clearly way out of its depth to deal with a pandemic situation like the one that we're facing right now. Um, the government is doing all it can. The private hospitals are doing the best. They're working 24/7 to try and do what they can. Nurses and doctors are doing what they can, but this is not a problem that can be solved overnight, unfortunately. And as a result, now it brings us to the point where we're almost at a point where the healthcare delivery system may not be able to take care of us. So what's the best that we can do within our own communities and within our own homes? And I mean, if it's taking hours to get an ambulance, and it's taking sometimes even days to find a hospital bed, what is it that we can do to protect those who live amongst us, our loved ones, our friends, our families, neighbors? And so the importance of building a support structure within your own homes, within your own communities, whereby while certainly you are not going to be able to replace the hospitals are very involved processes that require infrastructure and expertise that you clearly cannot build at in your house, or even in your residential community. um, you can probably put in place certain measures is to take care of certainly the mild patients, appropriately keeping the community safe, and maybe to some extent even possibly moderate patients till you get the availability of ICU beds, or even regular beds if you may need it. Right. So putting in place some of these precautions is the need of the hour for everyone, because I'm sort of, I would say almost in the front line, in the sense that we work with several hospitals here, and I'm an ICU specialist doctor, and I'm constantly getting phone calls all day for the last several days asking me, do you know if there's an ICU bed somewhere? Do you know if there's a bed somewhere? Where can we send our loved one? We're at this hospital and they don't have a bed for us. Somebody is at another hospital and they don't have a ventilator for us, so we need to get somewhere else. And so these are phone calls that are the norm. I mean, this is what we're dealing with all the time these days. And so in this current scenario, and the way it's going in the coming few weeks to months, we can expect it to get worse before it gets better. So what are the things that we can do? Having access to specialists who know, who can give you appropriate advice in these scenarios is important. There is a deluge of information. There's a deluge of WhatsApp forwards. The media, in the current scenario, is publishing a lot of things, and it is impossible for lay people to make sense of it. And very often it is even impossible for just general doctors to make a sense of it. And so you need somebody possibly with the expertise to be able to sort of sift out the chaff from the wheat, and tell you what is appropriate to you in your case and what is the best thing for you to do. So building that sort of a support structure is going to be imperative for everyone in the coming days, because unfortunately, COVID is here and it's going to be with us for the coming weeks. So I'll end with that, and I'm happy to make this more interactive.
Yeah.
Taking questions.
Yeah, thank you, Dr. Dhruv. So we will be getting into details. I've been seeing the questions. So we will talk about the kind of facilities, what are the equipment that we need, what is it going to cost, the whole logistics of setting up, as well as dealing with patients who may need it, the type of patients that can be supported, and so on. But before that, I'd like Manish from Rohan Vasanta to talk about their experience of setting up this center in their, within the common facilities in their apartment. Manish.
Yeah. Hi. Thank you, Dr. Joshi. And I would like to take forward from what Dr. Joshi said. As Dr. Joshi facility and other medical facilities in Bangalore. So the whole idea of setting up this, this oxygen bed facility in our community was, we were hearing when Bombay and Delhi was at its peak, patients dying, waiting for the ambulances, and not getting hospital beds, etc. So what we thought as primarily when we set up this facility was that the idea was to, as a stopgap arrangement, while a patient is waiting for an ambulance, we could provide them some kind of support till he gets a ambulance or a or a bed in the hospital. But now going forward, we saw that the government of Karnataka has come up with guidelines, and they are requesting communities to make this more of an oxygen bed facility where mild to moderate patients can be treated, right? Or see, we are not trying to keep anybody there and them treatment. This will come only in use when there are no beds available in the city, and the patient needs some kind of basic treatment, and some kind of basic treatment can be provided to the patients. So we are still, we are a very basic now, and with some more inputs from experts, we would like to, enhance this facility. And if need arises, we would like to, do the best if somebody requires it.
Yeah,
that's about it.
Thank you, Manish. Before we get to the questions, I just want Vikram Rai, who's the General Secretary of Bengaluru Apartment Federation. Vikram, you're there, right?
Yes, Miranda.
Yeah, hi Vikram. So Vikram, if you could just quickly talk about your conversations with the government in terms of BBMP has specifically clarified what kind of approvals are required, how to register your center, and also there are some people who are asking very rightly about liabilities. What is the role and the responsibility of the RWA?
Yeah, so I think like Manish mentioned earlier, there is a guideline which has been put out, of course, which has come out more in terms of the evolving nature and need itself in the first case. I think that was a natural progression towards that, and we've been in touch with the teams from BBMP and the health department to sort of proactively enable something like that, right? Not more from a reaction, but more from a readiness. But having said that, I think the background work which has also been going on in consultation with multiple healthcare brands, hospitals, etc., is to understand the nature of the solution itself, which needs to be put in, right? Because that's very critical to understand. And I think the panelists earlier made a commentary on that, that it's not just about you need a complete system to make sure it is in place, so that this is a clinical issue, right, at the end of the day. But having said that, I think what has happened from a guidelines, one is there has been an enabling guidelines, which I think now allows for resident welfare associations to collaborate with service providers, clinical and non-clinical, to either support residents through a home isolation mechanism or a in-situ COVID care center kind of a mechanism, or even some kind of an institutional or a hotel isolation kind of a mechanism. So that guideline enables and permits RWS to go forward with that. And what we have heard based on the last call which the BBMP commissioner and the health commissioner hosted was that the liability is not some, and bunch of us had that question saying that, what is the responsibility liability coming in? So the response of them was that this is something which we are all doing for the public good. It's a public health issue. So please go ahead and do that. There will not be any challenges or problem to that. So it's more an informal sort of a stated assurance, if you could put it that way. But having said that, yes, I think from our perspective also, we do believe that is a reasonable clarity to having given to move forward, right? But having said that, I think the overall architecture has to be well built, which is what we are trying to put some effort on currently. As of yesterday, I think they have also, BBMP has put in an online system for any in-situ COVID care center to get registered. So there is a simple form which says, who are you, who's the person in charge, number of people, what facilities you have. They want that COVID care center to be registered. So I think it's not a permission per se. The guidelines is already a sort of an auto permission document. I think if you are setting up a COVID care center, if you're setting up a center only, in situ center, then you need to register through a link which BBMP has put up, right? So at this moment of time, enabling guidelines, go ahead and do it, but collaborate with, and that's at least what is our very, very firm opinion, that you need to have good, clinical partners like the panelists in this session, who need to guide associations to, because it's not just about infrastructure, it's not just about equipment. I think it's about a holistic management of overall cases, right? How do you decide somebody is asymptomatic? How do you decide somebody can be in home isolation, etc.? Right? So need to think to the full value chain.
Yeah, Vikram, if you could just put on chat the link to the registration, that'd be great. I just want to add one thing. There is also a government initiative to ensure that there's a decentralized management of the situation. So at the ward level and the booth level, there are interventions. So they're creating these, block level officers for every few hundred houses and with volunteers. So whatever we are talking about now, whether in terms of, keeping track, contact tracing, setting up care centers, all of this will also feed in and integrate with the larger system is what, need to be considered. So if I could just ask now Dr. Ferzaan to explain very quickly about the facility, what kind of facilities required? Can you use a clubhouse? Can you use like a lounge area, or does it need to be, independent rooms do you need? Can we also look at houses which are empty? How do we set it up? What are the equipment that we need? What should not be there? For example, many people are talking about oxygen cylinders. Is it okay to get it? We don't want to hoard those also, because it's, you need like expertise to manage that also. So what is it as residents we could do? Dr. Ferzaan.
In our case, it starts with the home before we move to the clubhouse. So we would sign up a community. We would have everyone's information, demographics, records on our system so that we can respond quickly. And if someone has a problem, they would call into our platform and talk to a doctor. And the doctor might say, well, let's monitor these symptoms, take some simple medicines. We can deliver, by the way, medicines and small equipment at home, at the doorstep. And then you monitor the person digitally. The nurses call, doctors call. And then you might decide to order a COVID test. And that would tell you whether the person is COVID positive or negative. If the person is negative, the doctor will just continue with routine treatment. If positive, and assuming comorbidities are low, the age is right in terms of safety, the symptoms are the person is either asymptomatic or mildly symptomatic. There are also now some interesting numbers in the COVID PCR test that could be indicative of how serious this is going to become. So you take an overall sort of view of the patient. And at this time, in most communities, assuming the home is adequately equipped, we would recommend home quarantine. Not so much in the community clubhouse, but home quarantine. As long as the home is able to, has the basic sort of wherewithal to do this. If it doesn't, and you live in a big community and there's a clubhouse and there are rooms in it, there are adequate bathrooms, etc. I suppose one, and the home is congested or has vulnerable people within it, one could conceivably move a few people into that facility.
Dr. Ferzaan, sorry to interrupt you. You alluded to testing. I mean, are you guys able to support or facilitate the testing process?
Yes, we are. And I think it's very important to understand what are the tests out there, and what they actually mean and how accessible they are. The standard test is a PCR test. One would have to go to a testing center, and now there are some agencies which will do the collection at home. People come in a full PPE and they can collect samples. It used to take about a day to get the results. Now it can take as long as 3 days. So one has to be cognizant of that. Another interesting, so the PCR test will be both very sensitive and very specific. You will almost never get a false positive. And after day 4 or 5, it should very reliably pick up COVID. But it has the problem of being expensive and time consuming. There is another test which is called the Antigen Test, which has just about come in. And that should give you results on the spot in a few minutes. The problem with it is it's less sensitive. It's specific. So let's say there are 10 people with COVID. For 6 or 7, it will give the right answer. For 3 or 4, it may give a false negative, meaning it says you don't have COVID, but you actually do. So when you use a test like that, then you would very carefully watch for a few days for symptoms. And obviously, if you tested negative and then there were no symptoms, you get a little more comfort. You could presumably, in a few days, repeat it, because if you were too early for the first one, when you repeat it, you might catch it. But having said that, the gold standard remains the PCR test. The antibody tests, which are much talked about and now I think offered quite freely. Sorry, Meera?
Yeah, no, I was just asking, so the once tested positive the first time, when do you recommend the second test based on how the symptoms proceed?
My understanding is that in regular circumstances, the guidelines do not require a retest. You just sort of quote unquote serve your time in home quarantine, and then you do not need a retest. There will be clinical conditions where I suppose retesting is sort of wise, but in a mild case at home, when you finished your quarantine period, My understanding is that the current guidelines, and I'll ask Mr. Rai to confirm that, retesting is not prescribed. What you could do, let's ask Mr. Rai. What is my understanding correct, sir?
That's correct, doctor. That's correct. I think I well put by saying serve your time.
Yeah, because Vikram, the reason I was asking also because there's a lot of confusion between different departments in terms of, sometimes BBMP is like, recommending the second test. Sometimes they just say serve it out. So, so we did see these different
I think
sort of conflicting
my understanding
recommendations.
of that, Meera, has been that there is also, and I'll allude to what Dr. Engineer mentioned as well. I think there has been a lot of confusion in terms of the accuracy of the testing as well. I think we've seen quite a number of cases where there have been false positives which have been asked to test again, and we are hearing continuously the cases of where people are being asked to test again, right? There was also a time frame when people who were coming in as travelers, because they were put through something called as pool testing, right? Which also I think meant that they had to go back for a second test. But having said that, I think somebody who's reasonably, who's confirmed as positive, has gone through their time and treatment, don't need to go through a...
And then after the 2 weeks, there will be a test to confirm that they're negative, so they can be moved out of quarantine.
Let's talk about this a little bit more, and then maybe also get an opinion from Dr. Dhruv. Meera, I don't believe if you're mildly symptomatic and you've finished the 17 days or whatever, I think they start counting from there's one count from the day of test and one count from the day of result. After that, my understanding is one does not need a test if, I presume, clinical symptoms are absent and the doctor comfortable.
So, and that situation is what, like 3 days without fever? How do you define the absence of symptoms?
I'll defer to Dr. Dhruv, but I'll make one or two comments first before that. I think it would be interesting. I just wanted to finish on the antibody test, which are very widely publicized. They're easy to do because you use blood and you don't have to, worry about infecting the person who's collecting it and so on. There's less of a risk. The antibody tests are almost useless for determining what you should do as a patient or a consumer. They're only useful in terms of epidemiology. So if you do a large number of tests in the city of Bangalore, you might be able to say in this district or in this community that there was a lot of exposure.
So we are talking about RT-PCR primarily now.
No, we are not. We are talking about serological antibody tests.
No, what you're saying, that's what is recommended. RT-PCR is the gold standard.
No, so let's walk through this. So I am at day 0, okay? I got infected today. RT-PCR will start picking up my disease probably as early as day 3, but more reliably at day 5. If I've been infected today, no test will pick me up. Maybe after 3 or 4 days, RT-PCR will pick me up, and it'll pick me up with 100% reliability if it's positive, or almost 100%. If I do an antigen test, it'll pick me up later. Okay, and then I don't test. If I'm mildly symptomatic, I'm at home, I'm taking my medicines, I'm talking to doctors. If I'm a complicated case, I'm talking to a super specialist like Dr. Dhruv, and then hopefully I recover, my 17 days are over, and then I'm done. If I then do on say day 21 or 22 or whatever an antibody test, and I test positive, it could be a good thing because you have IgM when you're fighting the disease and IgG when you're cured. Right. And you might say then I might have some level of immunity for a certain period of time. However, how much immunity I'll have and for how long is not fully known. And therefore, one could be in a euphoric state that now I have IgG and I can just sort of...
so it's important to play it safe even later.
Yeah, but I think Dr. Dhruv is the greater expert. So let's hear.
Yeah. Dr. Dhruv, if you could just talk about this as well as maybe get into the previous question of setting up the facility. What are the equipment that would be required in a community center, and what would it cost, most importantly?
Yeah, sure. So again, just to reiterate some of the things that Dr. Ferzaan mentioned, gold standard test remains, and this can be a lot of jargon for people to figure out. I think good places to go to would be ICMR website, the BBMP website, and have access to a specialist if who can walk you through this. That would be helpful. But I'll try to make it as simple as possible. The RT-PCR remains the gold standard test. And that's the one that can take anywhere between 24 hours to up to 5 days right now, because there's a lot of backlog. There are not that many RT-PCR testing sites. It requires the setting up of a lab that can do RT-PCR testing is not easy, takes a long time, and it needs to be done in established centers, and there are not that many of those out there right now. So the other test is the antigen test. The antigen test, if it comes back positive, you can assume that you have COVID. If you are symptomatic and it comes back negative, the recommendation remains to try and get an RT-PCR test, right? So that's with regard to the antigen testing. The antibody testing really does not have much relevance here. It's more for epidemiologists and population health level studies. So at this point in time, I know that there are lots of WhatsApp forwards and lots of stuff saying antibody testing. My recommendation would be to be wary of those right now. They don't really have a lot of meaning. And until we have better guidance on the antibody test, I just wouldn't get carried away with those. With regard to the retesting, as of right now, there is no need for a retest. If you have a positive test and you are asymptomatic, you basically need to quarantine for 17 days. And that 17 days starts from the day that you have tested positive if you are asymptomatic, and the day of the onset of symptoms if you are symptomatic. And also you need to be fever free for 3 days. So it is and fever free for 3 days. So that's what you need to, that's as simple as I can make it. I mean, this can, like I said, complicated, but that's as simple as I can make it. With regard to setting up COVID care centers, again, I think the BBMP has outlined guidelines. The government of Karnataka website has guidelines on what the guidelines on what should be there and how they should be. Just to speak briefly to it, I mean, people can go and refer to it, especially the folks representing resident welfare associations can look into it with in detail, in depth. But just briefly speaking to it, they have mentioned in that document, it can be an empty apartment, it can be a large hall, they can be individual rooms with preferably an attached bathroom to it. If it's a large hall, up to, they have mentioned, if you can maintain some up to 6 feet gap between beds and have access to a bathroom, for at least a common bathroom there should be segregation for women and children and men. These are some of the guidelines that are there. I think anyone from the resident welfare associations who have already looked at it could probably speak to it better. And anyway, that's available. I would just use those guidelines and go by that. Again, I think what the other thing that I would say is that we're doing this in an unprecedented situation, and so while the goal is to follow what the government says, what the BBMP says, I think that should be what everyone does. But at the same time, just be prepared. Some of these things can change, and the bandwidth of the BBMP is also pretty limited. So that's where we come into, should you have oxygen or not? What type of oxygen should you have? Now, in ideal situations, if somebody is requiring oxygen, they should go to a center that is equipped with oxygen, a hospital, and get oxygen there. What's going to happen is that we're going to, in high likelihood, find ourselves in a situation where you're probably not going to have enough of those centers available, or it's going to take you a long time to get to those centers. And that's where we come into the point where you can have oxygen. Now, the oxygen, how do you get oxygen? Again, this is also not easy. There are two ways you can get oxygen: through cylinders, you can get oxygen through concentrators. There is a limited supply of concentrators. There are regulations regarding how many cylinders you can have and how many you can stock, etc.
And it's
And I'm
also
sure,
dangerous to have
and it's
so many cylinders.
exactly so there are regulations regarding, you know, keeping oxygen cylinders, where you can keep them and how you can keep them. Again, this is something that hopefully the BBMP will address. We're hoping at some point in time, because I do sense that we will come to a point where we are going to require all of this. I can tell you, just working with hospitals, hospitals that have access to oxygen supply are running short of oxygen, because these hospitals never anticipated having so many patients requiring such high levels of oxygen, right? So we're working with many hospitals in Bangalore, and all of them are having to upgrade their oxygen is change to other modalities of delivery of oxygen, or talk to their supply chain and bolster the supply, just because the amount of oxygen that is going to be required to take care of such a large number of COVID patients is even more than what hospitals can manage right now. So that's the message that I'm trying to get across, and maybe I may be a little blunt in saying this, is that the need of the hour is to fend for yourself a little bit, right, as best as you can. Because while we are going to be dependent on the BBMP and going to be dependent on hospitals, the reality of the situation is that most of them are out of their depth right now. The band, they don't have the bandwidth to be able to cater to all of us the way that it's needed. And so that comes into the point where, if you have the ability to have some oxygen concentrators, where people who have access to expertise or who are trained can help you operate those and run those, and you can the residents amongst you that are requiring oxygen and don't have access to beds, at least temporarily you're able to provide them with that oxygen, would be really helpful and can be life-saving quite often in this situation.
So what kind of staff do we need to caretaking do you need to support such a center? One is, you talked about the expertise who know how to deal with these oxygen, how to manage this equipment, right? But beyond that, even if we don't have oxygen cylinders or concentrators, what are the other things that would be there in this sort of, other than the beds and the linen and a place for waste management and so on? What kind of skills are required to support people in the, let's say you have like elderly people or people who are living alone who don't have anybody to look after them?
Yeah.
And this is a situation we need to be more bothered about, not the more than the seriousness, but it's the other support system that can be provided by the RWA. So what sort of staffing needs do you envisage?
So the good thing is that most patients are going to be mild. Most of them are going to have mild illness, and for mild illness, there's not a whole lot that needs to be done, other than some of the things that we mentioned. Having adequate spacing, having access to a bathroom, keeping people isolated, having access to N95s and PPEs for the people who are going to be interacting with them, keeping the other people safe. Ensuring your waste management. Again, all of this is listed out in the guidelines, the Government of Karnataka guidelines, so that is doable, and that is easily doable, and I think that is going to be the best solution than having mild patients go into hospitals that are already full and don't have beds, right? So that is not very involved. And in addition to that, again, like Dr. Ferzaan had mentioned earlier, this is a disease where the hope is that you will just have mild illness and you'll be fine at the end of serving your time, so to speak. But having access to expertise in the event that things change, because they can change. So you can have mild illness that suddenly becomes moderate, sometimes in a few hours, sometimes even in a few even in a few days. So having that support system where you have, even if it is if you have somebody in house who is a specialist, that would be ideal, but not everyone has that available to them. So at least having remote consultation available, and at least a nursing support who can just do monitoring, go talk to you maybe twice a day, ensure that you've checked your pulse oximeter, that your hydration levels are okay. These sort of things where basic nursing and having access to expertise remotely even is sufficient for most patients. Of course,
And what about
once we get into the moderate illness, then it's just a question of providing supportive treatment to them till you can get a hospital bed, and
right?
that may involve having to use oxygen, right?
Right.
And so like I said, the two ways that you can deliver oxygen are through cylinders and through concentrators. Getting cylinders, I don't know the guidance on that. That's something that we'll have to wait for the government to do. But
Okay.
oxygen concentrators are something that you can do, and they can deliver oxygen up to a certain level.
So, Meera, if I
What
can
about
be allowed a very quick comment here.
yeah?
We are managing maybe a dozen plus apartment complexes now, including an oxygen concentrator, sometimes two, enough supplies so that since you can't share those across patients, and we have trained the committee with our biomedical engineer. So the oxygen concentrator part is manageable, but about oxygen cylinders, and I wanted to double check with Dr. Dhruv. I was talking to a colleague today, and this is a moderate patient in a hospital. And I was told, Dr. Dhruv, rightly or wrongly, I don't know, that he would need 10 to 12 jumbo cylinders of oxygen in a day. Is that?
Yes. So just to give you a sense of how much oxygen, there is about 600 odd liters of oxygen in a small cylinder that you usually see, that you can keep in one of these centers, or you can keep at home. And if a patient is using the minimum amount of oxygen, which is 2 liters a minute, that in 60 minutes is 120 liters, that in that cylinder will be exhausted in 5 hours. That is if the patient is at the minimum amount of oxygen. Now, if he requires more oxygen, like for example up to 10 liters of oxygen, that cylinder will be exhausted in an hour. Right. And then when you get to patients who are moderately ill and require even higher amounts of oxygen, some of these patients require about 60 liters of oxygen, up to 60 liters of oxygen, using these what are known as high flow devices. Now 60 liters of oxygen would exhaust that cylinder in 10 minutes, right? So and a jumbo cylinder is about 10 times 10 times the small cylinder. So that would be exhausted in about 100 minutes. So in a day, you're going to go through, like you said, something like 10 to 12 jumbo cylinders for a patient that's requiring a high flow oxygen quite easily. And like I said, that was what I was telling you, that most hospitals are not equipped to be able to turn around these levels of oxygen.
So my thought would be to be very, very thoughtful about this and to study this carefully, because the virus doesn't read the newspapers. So it follows, I mean, it does its own thing. And we need to scientifically understand things very clearly. What kind of tests should we do? What should we not do? It's very easy if you don't go deep into the science to say, I'll keep an oxygen cylinder and then it's fine. But it's actually not fine if the person is moderately ill. So I think a deeper study of this from a scientific perspective, and then taking the right decisions would be our recommendation as a company.
Dr. Ferzaan, if I can just move into the cost aspect, and it's inevitable, even though we can talk about ideal situations, that is going to be a bottleneck. So what is the cost? You said you set it up in these apartments, the concentrators. What would be the cost of these infrastructure?
Concentrators.
I can give you a rough sense. And I'm saying a rough sense because concentrators are now becoming very difficult to acquire. As a company, maybe we've got about 60 or 70, and we are distributing it across all our cities. If you rent one, I think it's about 5,000 or 6,000 rupees, depending on how many consumables you buy with it.
Mhm.
And you would need one set of consumables for each eligible person who
Okay, this 5,000-6,000 rupees per what?
per month.
Per
Per
month.
roughly.
Okay.
Some of our customers have chosen to buy them, and we looked around, we shopped around, and the ones which we used to buy for 40 or 50,000, they're now either unavailable or 1.5 to 2x 70,000. And then there is another one which is less expensive but less known to us because we were always buying the more known brands. Those are 40 or 50,000.
Okay.
So I guess to purchase, you're talking, depending on whether the machine is new or refurbished, somewhere between 50 and 70,000, as Dr. Dhruv said.
Okay. And how many? Okay, maybe
And
I
they're
should
not
just move to
available.
Mukesh. Okay, sorry, Manish, if you could just talk about like how many you got and what it cost.
So we were looking at oxygen concentrators earlier, and the price of oxygen concentrator about a month back was about 70,000 rupees for one concentrator. And we were thinking of buying two of them, but it was working out very expensive. So instead, we moved to the oxygen cylinder system, which costed us about 10,000 rupees for one system completely, as Dr. Dhruv was explaining, administered at 2 liters per hour or so. That's what I was told. And now again, I thought we as association thought that we need to buy maybe a couple of more oxygen concentrators. And the price is somewhere around 80 to 1 lakh rupees. And more importantly, a couple of vendors I spoke to them, they are not available. Oxygen concentrators at the moment, I couldn't find a vendor who could give me one. So,
so when you talked about cylinders also, the fact is that you have doctors and their expertise within the apartment who will actually like support that, right? Otherwise, there's no point in just sitting with the cylinder if you don't know how to use it.
That's true. So we are one of the fortunate, we are one of the fortunate communities where we have about 4 or 5 doctors living in our community, and we have contacted them, and they have agreed to come and help us in case of any such emergency or if need arises. So,
to summarize, you have cylinders which will last 4 or 5 hours, and you have the in-house expertise to support. So this is like this interim, point before patient can move to the hospital.
That's true. As Dr. Dhruv was explaining, so we have the oximeters, we have the blood pressure machine, and general those PP equipment and all those things, right? So
and
this is
what did those cost? Like what you bought pulse oximeters, you bought PPE kits, you bought BP machine, right? And how much totally? How much did you spend? Just to give a rough
so this
estimate.
The whole for the one set of oxygen cylinder and pulse oximeter and put together about 20,000 rupees. So if we have created 2 oxygen cylinders with pulse oximeter and all, say about 40,000 rupees totally it costed.
Okay. So 40,000 rupees, and the rest of the infra was available because you had ready rooms.
So
we have ready. Yeah, Dr. Ferzaan, please.
Sorry, I interrupted you.
Sorry. Please.
Please carry on.
No, we had ready guest rooms in our clubhouse. So the infrastructure was quite nice, what we had readily available, the nice guest rooms with attached toilets and all. So that was a very conducive kind of place where this oxygen facility could be made. So we did consult a couple of doctors before going ahead with this facility, and we kind of went ahead and created one.
So you use the common pool money to
it's all association money. It's all association money.
Have you considered, I mean, this is one question like a lot of people had, have you considered how to deal with the cost? Like, let's say, will you be getting it reimbursed from some patient if somebody falls sick, or this is going to be a public good?
I think we have not thought through this, but my opinion would be this would be for public good.
Perhaps from our experience.
It's a very typical association question, so I had to ask. Yeah.
Meera, I could very quickly summarize what some of our apartments have done.
Yes, sir.
We've done something similar to what Mr. Bansal said, spent 10 or 20,000 on putting some basic stuff in the clubhouse. And then they've signed up for a scheme where any resident can phone one of our doctors. And
Right.
for a relatively modest amount, I think it's about 150 rupees a household per month, something like that. They can make unlimited doctor calls. Now, if some of them get sick, then they have the option to buy our home quarantine program.
Okay.
We offer them, others offer them as well. The general price range and the specific price range for us is I think 3,000 and change, going up to about 16 or 17,000, depending on, you know, whether you want a basic service or you also want a nutritionist, a psychologist, you know, things like that. So let's say the average would be 6,000 or 7,000 a month for the home quarantine package. And then the COVID test, typically for an RT-PCR test, you would pay between 5,000 or 6,000, depending on where you go. The antigen testing, we have just applied in our hospital to the ICMR. I don't know the pricing yet, but it's probably between 1,000 and 2,000, something like that. But they are not widely available now. The RT-PCR test is 5,000 to 6,000.
Okay, and do you send the personnel to come to go to the house and then do the test to collect the samples?
We are not a laboratory, but there are laboratories within our ecosystem. And the one I've used the most extensively so far has collection centers and the ability to collect from communities. And they do the testing at Anna Newberg laboratories, but there are other labs as well.
Okay.
Sorry.
Yeah. No, I just wanted you to kind of talk about, in case there aren't empty flats, there aren't like large facilities to set up such care centers. Is there like any jugaad that you would recommend? What would be the minimally available facility that could be used?
I think it would be hard if you don't have an empty flat or some common facility. I think it's going to be hard to sort of makeshift put together something. It's possibly doable. A jugaad-like situation like that is possibly doable, but that'll have to be thought through on a case-to-case basis. I just want to address, I see a lot of questions coming through on this oxygen. I think maybe it's not clear. So there are two ways in which you can give oxygen. One is through a cylinder, and which has compressed oxygen in it, and it has a finite amount of oxygen. It's an oxygen cylinder, right? And so you have these cylinders usually have about 660 odd liters of oxygen in each cylinder. The other way is the oxygen concentrator, which is a machine which is connected to an electricity supply and has a battery backup as well. Most of them do, at least the good ones. And they are able to create and deliver oxygen continuously, right? So it's not a finite amount of oxygen. They are able to continuously, as long as they are connected to electricity or have battery backup, they are able to deliver oxygen. And they are able to deliver oxygen up to a level of, most of them are able to deliver oxygen up to a level of 5 liters per minute. Some of the oxygen concentrators are able to go up to 10 liters, but those are not commonly available. And even the oxygen concentrators that are able to deliver up to 5 liters per minute are in short supply. And I don't think that we will have them available for much longer. That is my thought on this. As people start getting these and purchasing these, and the supply of these, a lot of these need to be imported. So I don't know what that supply chain is going to be like, and when we're going to be able to get more of these. So that's the reason why I was saying that it is probably in the government's best interest, and even for societies to start seeing how oxygen cylinders can be used, because they can be refilled. Right, so you can keep refilling these cylinders. It's just a cylinder. There are oxygen manufacturing plants in the city, and you just need to keep on going. They can increase their production of oxygen and keep refilling these cylinders. So at some point in time, it may be necessary to consider a strategy where you're using cylinders because you don't have access to concentrators.
But how do we get the, the expertise who will to operate the?
So it is the same way as the cylinder. So regarding the expertise, what I would say is that you're going to require some amount of training. What happens is whether it's a cylinder or whether it is a concentrator, it is going to come with some consumables, which will include like a cannula, a piping that connects to the cylinder or the concentrator and goes to the patient.
That will be individual for each patient.
Yeah, that is going to be individual for each patient. And one person, you can connect one such tubing to either a cylinder or a concentrator at a time. And it is only for that patient. You dispose of it once you need another patient to use. Get a new set of consumables or a new tubing that you put into your concentrator or your cylinder. So this is something that will probably require, I mean, if it's associations where you train a few people on how to, maneuver the oxygen cylinder, how do you turn it up or turn it down, how do you use the concentrator, it would probably be the same for both. Right now, again, I think people are using concentrators because it's easier. It's a continuous supply, does not need to be refilled. The reason that I'm talking about the cylinders is for the reason that I mentioned, that we may run out of concentrators, which we probably will.
So I have a question for Dr. Dhruv. Oxygen concentrators, I know, are not available right now, but you are saying that even oxygen cylinders are in short supply and we may not run out of it. So how do we deal with such a situation in case a need arises after getting a facility and the oxygen cylinder will last you only for, say, about a couple of hours? So what do we do then? How do we deal with such a situation?
If you are going to go down the route of oxygen cylinders, you will have to have backup cylinders available. It is easier to get oxygen cylinders than oxygen concentrators. You have to take a little bit more precautions in terms of store and refilling, etc. And you will have to figure out, who's going to refill your cylinders once they are empty. Usually, what happens is, it's like an LPG gas cylinder, right? They're going to give you another cylinder, they'll take the cylinder, and they'll give you another cylinder. That's how it is.
Hopefully, like supply will improve now that the need is there. I'm sure more.
My hope is that the government and possibly even associations start working on this supply chain by which you are able to do this. Ideally, if you ask me, what do you do in this situation? Right now, there is nothing. If you don't have a concentrator, you don't have a cylinder, and you don't have a hospital bed, unfortunately, there's nothing that you can do at that point of time. And that's really sad. The hope is that, if you were to ask me ideal scenario, what would be the best solution that you can think of right now? I would tell you that if we can set up like a Swiggy or a Dunzo like service for oxygen cylinders, where people are just keep refilling them and distributing them and refilling them, going there, that would be the ideal scenario. That does not exist. If somebody is going to go ahead and do that, I think that would be
people must be working on that.
Yeah.
Okay.
If I could make a quick comment, Meera.
Yes.
It's important to understand that a concentrator actually makes oxygen. It concentrates oxygen from the air.
Yeah.
And the only thing it needs is electricity. So if your electricity fails, it doesn't work. That is the only risk factor. Whereas with the cylinder, your risk factor is you run out of gas and you don't have another one.
Dr. Dhruv talked about battery backup for some of them. So, and at least from an apartment perspective, we do have, DG backup. So that may be a smaller issue.
A lot of surplus fuel these days.
Yes. Then it's de-risked. Now you could rent a concentrator from us, from Nightingales, subject to availability. They're available now. We're trying to buy new ones. And if you then want to buy, you can place an order for them and rent till the new one shows up. So I think you should try to rent. We also send a biomedical engineer home or to the clubhouse to train the committee. And then further guidance could be provided by a resident doctor or one of our doctors on a video. So there are solutions available. I guess you need to figure out how many residents there are, how much you need in terms of number of cylinders or concentrators.
So if I could just go back to you, sorry.
Quick question to Dr. Ferzaan. The apartments with the 100 flats should have how many liters of this oxygen cylinder?
Uh, I'll defer to Dr. Dhruv. Uh, I would say for the ones we are working with, they would pick for 100 apartments, maybe 3 oxygen concentrators. Uh, uh, the cylinders question is, at least to me, a very scary one, because how many do you need? I mean, if you're going to go through dozens of jumbo cylinders, and a jumbo cylinder won't even get into a house. You need much smaller ones, and then you need a much larger volume. So on the cylinders, I'm personally very hesitant to comment, although on request, we have provided our customers a couple of cylinders. I actually think I have more confidence in the concentrator solution. Number of cylinders, I would find it next to impossible to answer. Maybe a couple till the ambulance arrives, but maybe Dr. Dhruv knows better.
Yeah, I agree with Ferzaan. I would say that I would suggest that if you can get concentrators, that should be your first go-to, because you will have a constant supply of oxygen as long as you have electricity with the concentrator. Once you get into the cylinders, the reason that I talk about cylinders is because it is possible that we may come upon a situation where you don't have access to concentrators, but as long as you do, you should probably go ahead and get concentrators. There are several disadvantages of having oxygen cylinders. There is only one advantage of having oxygen cylinder. The amount of oxygen that can be delivered from a cylinder is higher than how much can be delivered from a concentrator. So a concentrator can go up to 5 liters per minute. From a cylinder, you can go up to 10 to 15 liters per minute. So if you have a patient that is requiring more than 5 liters per minute, a cylinder may be able to help you out. But again, the problem with the cylinder remains the same, is that it will run out. So if the patient goes to 10 liters per minute, that cylinder will run out in an hour. So that one cylinder will be done in an hour. So
Okay.
for the time being, the use of the cylinder should be till you can get an ambulance or get to a hospital. From a long-term standpoint, if you run out of or don't have access to concentrators, then you can start calculating. Just assume that you're going to require 5 liters per minute, which is how much a concentrator gives you, how much oxygen a concentrator gives you, right? So if you're going to require 5 liters per minute, in an hour you will go through 60 into 5, that's 300 liters. And 300 liters, you will run that cylinder in 2 hours, right? So for 24 hours, you would need 12 of these small cylinders for one person if you were running it at a minute.
Okay. Let me just go over some of the questions that have been shared on chat. A lot of questions on waste management. You can see some of the points in the earlier webinars on ADDA. But as far as I understand, BBMP has specified 4 bio-waste service providers, because BBMP is supposed to collect the waste from positive households, but I think again, like they are loaded, it's not really happening. So there are 4 service agencies. There are also private agencies like Hasirudala who do pick up for a different charge. They recommend that you tie it up separately. Vikram, do you want to come in with how the BAF members are dealing with it? For example, people still segregate, people in quarantine or isolation are still segregating. They try to manage the wet waste in-house using cocoa peat and all that to kind of delay. You can, collect the waste later on, but the immediate daily collection is the challenge, right?
Yeah, I think, and that's an area which is unfortunately has had a little bit of a lag, and that's really a concern, right? As far as the systems being ready for it, and which is why I think even the question about running a COVID care center needs to be thought through, not just from the point of view of what is the clinical equipment, etc., that you have. I think there's a lot more to it in terms of making sure that at the end of the day, I think the facility, if you look at an exclusive facility, houses patients. They're asymptomatic, whatever it is, but it needs to be thought through in that sense of caution. Waste, for example, Dr. Ferzaan mentioned in the beginning about there being adequate number of toilets and all that. Those are all very important critical parts which the association needs to know, because we might have piece service providers for each of these, but how do you then tie that into something which is reasonably good enough from our side? So waste is one area. There's been back and forth, but yes, you're right that at this point of time there has been some clarity which has come up. In between, even people like Hasirudala, etc., had a confusion because they were ready to pick up, but BBMP had told them that only they have to be given it, but they didn't have the back-end infrastructure or the number of medical waste managers who could handle that. But I believe last week that has been clarified and updated on that part. So yeah, people like Hasirudala can collect that waste and hand it over.
It has to be separately handed over, tied up in.
The entire quarantine contained zone is treated as biomedical waste, and it needs to be. But yeah, like you rightly said, we have sort of tried to innovate within ourselves and say that if there is no clarity, then do some coco peat and
because wet waste you can still have it inside the house, and that's not you want to minimize the waste going outside.
But we have also had questions saying that will that compost be infectious, which and questions like that keep coming up, right?
So the expert response to that was been that the fact that the compost is like hot enough, there is a lot of heat inside, so it does,
like
it can't survive.
About STP treated water and all that kind of stuff. Right? So these are all loose ends which I think needs attention. Unfortunately, there are not 100% clear case answer. It's by discovery, right? So, but yeah.
Right.
If I can add just a quick thing here, Meera, just a quick comment. I would urge the apartments to first think digital and then think brick and mortar. First, exhaust all your options in the digital domain. You can do teleconsults, you can do video consults, you can have stuff delivered to your doorstep. You can have a COVID test done in 2 minutes of physical interaction, which is not digital, but it's very little physical interaction. I would say exhaust all your digital options first before thinking brick and mortar.
Right.
Okay. Also, one question what I have is, among the communities, one question they have is, God forbid, if somebody has COVID symptoms, or if somebody thinks that he needs help with, if somebody say COVID positive, so what should one do? Should they take a BBMP route, or they should take the private hospital, family physician route for the treatment? Earlier in the earlier days, we used to hear that once you are tested COVID positive, the BBMP guys would just come in and they would take you away and put there in Victoria Hospital or wherever. But I think that is not the case right now, and there is not much clarity on this thing. So can somebody please throw some light on this, and what is the SOP if somebody thinks that he's COVID positive or whatever?
Maybe I can. Oh, sorry, Dhruv, go ahead.
Yeah, no, happy to take that. I would, I again would reiterate what Dr. Ferzaan said. Go digital. A lot of this can be managed at home without having to go into a hospital which are already full and further expose you to problems and overall are not a pleasant experience for most people. I don't think that anybody would tell you that the BBMP has to do what they have to do, but I don't think that is a pleasant experience for anybody, and can be safe if it can be safely done at home with access to expertise digitally. That's what we should do. Again, it's important to have expertise because again, we're living in unprecedented times. Treatments come through WhatsApp and newspapers, etc. And not all of these are harmless. So, it's important to have access to the right person at the right time who can guide you through what needs to be done. The treatment is a little different. The medications are different when you are requiring oxygen and when you're not requiring oxygen. And these are not things that can be easily determined by people themselves and will require. But again, all of this can be done remotely. So
just to clarify, Dr. Dhruv and Dr. Ferzaan, so all the facilities, your services that you're talking about so far, the home care and the remote, all of that is remote, right? You don't actually have any doctors coming like once a day and all, because some of these, the care centers that are set up by some hospitals in partnership with the hotels, they're actually promising like one doctor visit a day. So that's another, I think, model that seems to be available, right?
Yeah,
Let me,
that's.
yeah,
Go
sorry.
ahead.
No, go ahead. Go ahead, Dhruv.
Yeah, no, we what we're talking about is all remote, and I think that is both sustainable, it is safe, and it at the end of the day provides an experience for the patient that is comfortable to them, where they have a support system that can take care of them in a safe manner. That's really important in this setting.
Okay.
Doctor,
There is no contradiction here in some sense. So let me explain. Most of the services we are talking about are digital. The COVID test obviously is an exception to that, but it's a very quick interaction, and then it happens in the digital domain because you get your results, etc. Um, the sort of halfway houses that you're talking about, where you're somewhere between the home and the hotel, and the hospital, sorry. Uh, 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 I think they have a place. If in your house you cannot manage uh, a mildly symptomatic case, or you have a person who can't be safely kept at home, although the symptoms are mild.
Somebody is with comorbidities.
So there is a certain place for them, where I would advise, and for example, in one of the big communities here now, they said, well, why don't you set up a day clinic where you have a doctor and a nurse in full PPE, and you interview all the help and drivers in the colony. And we did that for them. There was another logistics company which wanted uh, their drivers remotely tested before they fan out into the country. So we did those. So there are various kind of solutions that are there. What I would caution against is saying, look, I set up in my clubhouse 6 beds and I'm going to have 24/7 nursing. I mean, that's impossible, because you would need an army of nurses in PPEs who only last in the PPE at best for 6 hours. They need 2 days of holiday in a week. And in the first place, they don't exist in enough numbers. So that is what I would caution against.
Thank you. So we are kind of running out of time. So there are 2 key questions I see here, and then we'll, based on the time, we'll take it. Also, there are questions related to emergency contacts, list of resources and so on, which we can take it offline, as in we will take these questions and put it out on social media or on the website, saying here is this link to the list of fever clinics, list of ambulances and so on. So we won't take those now. Regarding the question about the permission or the letter from BBMP before a patient can be admitted to the hospital, I think that's a key question. If somebody would like to answer that, do we need a letter from BBMP before a patient can be admitted in the hospital? What is the current rule on that?
I'm sorry, I didn't get the question.
Earlier, they used to be BBMP would give the government would give a letter saying, yes, this so and so needs to be admitted into the hospital. Till a few weeks ago, that was a norm. Currently, based on clinical diagnosis, you would.
Yeah.
Okay, so there is no such rule right now. Based on the severity of the case, they can be admitted, right? That's
okay. 1 minute.
1 second, Vishwa. Yeah. Okay, yeah. Vishwa, this was your question, I think, right?
Yeah, it is a 1200 apartment flat in Bangalore from Mantri. Okay. So what has happened is the patient turned to be positive. We couldn't get the BU number. Finally, with some through sources, we got the BU number, and we were contacting the BBMP doctor. She has straight away denied, saying that we cannot admit him, and we had to use our internal references from political side and get a ICU, because his oxygen levels has come down to 65 from 88 to 65 in a 6 hour span. So this question was posted on particular scenario. What should be done? If we wouldn't have got that ventilator, I don't know, he would have lost his life. Okay. And then when BBMP corporator and health inspector had come down to our apartment, when we questioned, they say that it has to come through BBMP doctor to Victoria Hospital or Boring Hospital or Rajiv Gandhi, but getting a ventilator is difficult. So
that was specifically for the government hospitals, right? Is that what you're asking, or? Even
No,
the private
see,
hospitals are expecting.
no, even private hospitals like from Manipal and Fortis, we could get one ventilator bed through internal references. But the thing is, they say BBMP doctor has to call and update us if they want to admit, or else you get a permission letter. And Dr. Sudha, she straight away rejected, saying that no, I cannot give the letter.
Yeah, this is a question which I also had,
Okay.
Can't-
Vikram, do you have an example, I mean, situation
Yeah,
right
I
now?
think
Do you have a
that's
clarity?
what Vish was saying, until certain time, there was a process
Right.
roadblock which was necessitating for that BU number, right? So the test result needs to get validated, uploaded on some ICMR website.
ICMR site, yeah.
BMP should come to know about it, and then they issue a BU number. All bureaucratic steps, right? Which was creating the time frame for the recognition of admission being extended. But I think last week sometime the government categorically put out a communication, the BBMP has put out a communication saying that admission should not be denied for the lack of a BU number. So that message is very clearly gone to all private and public hospitals. So I don't think so that is still
This is not the current
necessity. But on ground, how it works, of course, all that questions remain.
Sir, this has happened just 3 days back, and the same day this notification, whatever you said, right? The notice, even we have seen it, but this is all on paper. On reality, this doesn't work at all.
Okay.
I agree. I think
thank you,
I agree. I mean, it might be the case. I don't deny.
Right. Vishwa,
Vikram,
thanks
let
for
me
that. I mean,
ask,
if I can just say, this is something that needs maybe like further exploration of this issue. I will take this and, let's figure out what's really happening and why this, BU number issue is happening. We will take this offline and we will share this on, whether social media or on the website, like saying what really we found out, because we don't, I think, have an immediate answer to it. It is a problem. Fair enough. I just have a last, there are many other questions we need to wrap up now. I will ask like one last question to maybe Vikram and Manish on how do you go about convincing residents that this is important, because they're also scared. How do you get everybody on board and also at the same time keep them safe? So if you could just respond to that.
Yeah.
And
this was one of the challenges which we face in setting up the facility. What we set up, like some people were very resistant, and hesitant in setting up a facility within the premises, because there was certain amount of risk involved. They said if something happens, say God forbid, if something happens to the patient or something, then who's going to take responsibility? And we are not here to medically treat anybody. But then the whole purpose of this facility was not to medically treat anybody. As I said, it was a stopgap arrangement. It was only for the transition period, when the patient has to be shifted from his home to the hospital, and if ambulances are not available for the transition period. And yes, there was some resistance, and we had to convince him. And later in our apartment, we had to go through that majority voting route, and that's how we had to tackle this difficulty.
Yeah, if I may just add, I think great point. And examples like Manish's are I mean, very important to get that early sort of confidence, right? I mean, they've already bitten it, right? So we will now go and talk to everybody saying that, what Rohan Vasanta has implemented, or I mean, taken the lead, right? It's always about who starts first kind of stuff, right? Then there is a little bit of a cascade that people like us play a role too. But fundamentally, what I would say is that one, there has to be a percolation of the messaging on the fear and panic, right? That has to be consistently subsided, right? Because I always keep saying this. I mean, about even a few weeks back, the consistent question which we used to get on a lot of our groups is that I have one positive case 1 kilometer away. Arogya Setu is telling me what should I do, right? it should change from there, right? You will now have cases in your building, in your floor, in your own home, right, etc. Like I've dedicated one room in my home as between me and my wife, we have said it's an isolation room in my house, because it's not about not expecting it.
It's not about if, it's about when.
You will be foolish if you're not ready for it. So be ready for it. And like how the experts on this panel have said, there's, I think, for majority of the cases through digital models, you should be able to manage it, right? From a community's perspective, I think that message has transitioned to say that, hey, we as a building will have cases at any given point of time. So all these systems that you get ready with is largely anchored around the community resilience mechanism, saying that, right? So you will not have beds, you will not have hospitals. Please stop expecting that to happen. The amount of resilience that you are able to build within your community so that you can largely take care. But if there is a need, then you'll connect into the system, needs to move forward. So I think, the communities are not yet still there. They're asking, of course, there are a lot of questions by residents on what does it mean. They're scared. Should there be a center? What will if children loiter around and get into that place, etc. Those are all serious questions, and no doubt, of course, we need to address that. But I think the confidence and the needs to grow, and the fear needs to subside. Over a period of time, there are also other questions like, if we set up a center like this, will BBMP take over, right? Or will there be people from outside who will be put in over into
That's
that?
true.
Right? All that questions are there, right? I don't, and there are no clear answers to that. Can we today tell? I mean, we have asked a question yesterday to BBMP saying that, will these centers be used for non-residents to be put in as well? They've said, no, you have all control. But is that a guarantee? No, there's no guarantees like that, right? But we'll have to take a slightly more broader long-term.
Take it as it comes, yeah.
I think the first step is everybody as a community should say, do we have a good digital home program system? Are we all agreeing to say that there will be cases? They will all need to be taken care. 80% can be taken care at home. So let's support them for that. For another 20 to 30%, which is intermediate support, right? Where, like how Manish is saying, it's almost like a temporary setup before they go to a hospital or a hotel, etc. I think it will be good to think about it that way, right? But yeah, confidence need to be pushed, grown, panic has to reduce.
That's true.
To understand what is happening in the outer world, because for today, I know for a fact that a lot of people who are asymptomatic and mild are also going and reaching and finding beds. Yesterday, I had a question from someone saying that, I mean, it sounded like he's a perfectly young guy with very mild, asymptomatic and nothing serious, but they're all running around of their committee to go and check for a bed.
That should not happen.
Yeah, so that is a little bit of a challenge still now, right? The natural reaction is to go positive, let's hospitalize.
Thank you, Vikram. I think we've kind of run out of time, so I will wrap this up now. We will take the questions from the chat and address those offline. And I now request San Banerjee to conclude the session.
Thank you, Meera. This was a very informative and useful session. And it is just that pertinent situation when community can come together, to eliminate avoidable suffering and death. So extremely useful information. Thank you so much, Dr. Ferzaan Engineer from Nightingales, Dr. Dhruv Joshi from Cloudphysician, and Mr. Manish Bansal from Rohan Basanta. Congratulations for being one of the early movers in getting these infrastructure in place. So we'd have a lot to learn from all of you. And thanks, Meera, for excellently anchoring this, like many of our workshops that you have done over the years. And Vikram Rai from BAP. BAP is doing a fantastic job. So apartment complexes who are attending and not part of BAP yet, I'd highly recommend that becoming a member of Bangalore Apartments Federation, because they are liaising with the government, with many RWAs, and something that I believe every city, every state needs. And last but not the least, Karnika and the marketing team of ADDA for putting this all together. So thanks to all of you, and all the best to all of us for taking these learnings ahead. Yes, Meera.
Thanks, San. Just to add one point, like I mentioned earlier, BBMP is setting up a larger decentralized management system. I think it's important for all of us to kind of participate, because we can't be sitting isolated within the apartment. At some level, we're also part of the community. It's better that entire Bangalore is prepared rather than just, individual apartments. We need to look at it, with a broader perspective also. So keep those in mind and volunteer where possible, and, and so that we can kind of emerge out of this stronger. Thank you.
Sure. Thank you so much, everyone.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Ferzaan. Thank you, Dr. Dhruv. Thanks, Vikram.
Bye, everybody.
Thanks, Meera.
Thank you, doctor. Thank you very, very much.